My name is Joyce Woo. I'm a pediatric and fetal cardiologist at Ann and Robert H. Lurie Children's Hospital of Chicago and an assistant professor of pediatrics and medical social sciences at Northwestern University Feinberg School of Medicine. I think the first thing is to make sure that the diagnosis is accurate. So, for example, CCHD screening can catch everything. A lot of diagnoses are still being made based off of good, solid clinical exam skills, such as detecting a murmur or detecting early signs of neonatal distress. A lot of CHD diagnoses are being uh, determined by those factors, and those are not things that AI can help us with. That requires a doctor to lay hands on the patient and to really understand a good physical diagnosis, a well baby versus a not well baby. The second thing, I think, is the knowledge that delayed surgery for a lot of critical congenital heart diseases is associated with worse long-term outcomes. So, I think there is a common misconception that keeping a baby on prostaglandins will maintain patency of the ductus arteriosus, which, allows for sufficient systemic or pulmonary blood flow, life-saving blood flow. But um, there are side effects to leaving a baby on Prostin, and there are side effects to long-term cyanosis. We have really good data, for example, showing that transposition of the great arteries, long-term and short-term surgical outcomes are worse for every day that the surgery is delayed after 3 to 4 days. If you think about that, that's actually like a pretty tight clock for a baby that's diagnosed postnatally with transposition of the great arteries. The diagnosis has to be made, they have to be transferred, the surgical planning has to be done, ideally by 3 to 4 days, or else there is an association with worse short-term and long-term outcomes. Similarly, we have similar data for a lot of single ventricle disease too. So I think a really, really thoughtful conversation with the receiving surgical center about the risk versus benefit of transfer, timing of surgery, comorbidity and size of the baby, degree of prematurity. These are all conversations that ideally should be made at the time immediately of diagnosis, because once the diagnosis is made, assuming a postnatal diagnosis, you're on the clock for getting the baby the fastest care possible. And I think the last thing, and this is asking a lot, I admit, because our neonatologist colleagues already have to do so much to stabilize and take care of these babies, is a general knowledge of the surgical capabilities of each of these surgical hospitals. Not all surgical hospitals, for example, have the capability of stabilizing a premature infant with single ventricle disease. Some of that may require very, very advanced techniques like a hybrid procedure that may not be available at their surgical center. Other thoughts are that not all surgical centers are the same. Some are very, very good at surgery, but don't perform neonatal surgery. So even though there's capabilities for cardiac surgery, that surgical center may not be doing neonatal cardiac surgery.
Mm.
So a really good idea and a really strong relationship with the potential receiving surgical centers and thoughtful conversations about it, I think is really, really important for these neonatologists that are, the life-saving step for these babies with postnatal diagnosis. I don't have a clear answer for you based off of the research because the research hasn't been done yet. This is sort of the first study to show a relationship between time to transfer and outcome. Uh, but based off of clinical experience, I think accurate and timely diagnosis is really important. Ideally, prenatal diagnosis and delivery at a surgical center. Um, If prenatal diagnosis is possible, but delivery at a surgical center is not possible, coordination with the birth hospital and the surgical center prenatally is really key. That's something that our center does because we're such a big referral center for a lot of rural Illinois and parts of Indiana. If we feel that a patient lives too far away to be able to deliver here, we will directly coordinate with the local birth hospital with a contingency plan in case the baby is born at the local hospital. If it's a postnatal diagnosis, uh, very, very strong clinical exam skills, as well as aggressive, timely detection of the disease itself and intervention. Uh, as I mentioned earlier, I think once the diagnosis is made, uh, a sense of urgency to transfer the patient to a surgical center because we do have data showing that later intervention is associated with worse short-term and long-term outcome. I think one thing that may not be immediately evident to those who don't work in sort of the sphere of cardiology and cardiac surgery is that when we receive a patient with critical congenital heart disease, even if we know the diagnosis, it's not nearly as simple as, okay, let's just go to the OR, in the next 4 hours. Because there are a lot of nuances to each diagnosis that need to be clarified before safely taking the patient to the OR. And those nuances often are determined at the surgical center, not from the referring hospital, just because it requires so much advanced imaging and uh, team input to make decisions about these nuances. So, for example, like for transposition of the great arteries, it's really important for us to understand what the coronary anatomy is before the patient goes into the operating room. Yet most uh, community hospitals, when they do an echocardiogram, they aren't delineating to that level of detail. All that to say that when a patient arrives to a surgical center, even if there's been a conversation that's had between the referring neonatologist or NICU with the surgical center, there's still a lot of preparatory work that needs to happen before the baby receives life-saving care. So with that knowledge, I think that's a huge reason why we see that those who refer that get surgery sooner tend to have, on average, better short and long-term outcomes. The other thing that's really important is that we have shown in our previous research that uh, different levels of neonatal care actually have different surgical timing. So what's quite paradoxical is that those NICUs with a lower level of neonatal care, and again, this is not determined from our study, this is using different data. NICUs with a lower level of care actually tend to have babies that get surgery sooner than NICUs at a higher level of neonatal care. And so the question becomes, why is that's even after we adjust for prematurity and comorbidities and the level of sickness of the baby. So the question becomes, is there something from a system standpoint that is actually driving higher level of babies at higher levels of neonatal care to actually get surgery later or paradoxically later? Um, so I I think as with many things in medicine, communication and coordination are important. But if we drive down to the even more detail than that, it's not even just communication and coordination. It's, I think, the knowledge on both sides, the transferring hospital and the receiving hospital, that timing is actually key. That earlier transfer may lead to earlier surgical planning, may lead to earlier surgery, which leads to better short and long-term outcomes.